Hi, welcome back to this live discussion of the second annual Caring Discourse conference. As you can see, I'm here with Sara Bigi from the Catholic University of Milan, Margarida Figueiredo Braga from the University of Porto, Dulce from the APDP, the Association for People Living with Diabetes in Portugal, and with Vito Evola from the Nova University of Lisbon. So, welcome everyone. I'm muting you, Dulce, just because I can hear a background noise, but every time that you want to speak, please just unmute yourself and enter in the interaction. So, in the conversation, sorry. So our keynote speakers have already made clear that when we talk of shared decision making, we should contextualize it both to the patients and the healthcare setting. In this discussion, we'll explore more this topic, discussing shared decision making in different healthcare settings and from different perspectives, from argumentation to educational therapy. So before starting, I just want I just have a quick reminder. So you can always comment on the live chat. In this case, please, and you can pose your question using the chat. In this case, please start your comment with the question for the speaker. But also, if you would like to join us via video feed and ask your question directly, please send an email to caringdiscourse@gmail.com. So we are ready to start this discussion. Thanks to be here. And I would start by giving the word to Srikan Sarangi.
Why is that?
Back.
I didn't ask for the word.
So if you have a question, this is your time. But you can also we have already other questions, so I can also give you the word after if you wish.
Yeah, I think it's a good follow-up from the first hour this morning.
Mm-hmm.
And now we have 4 specific contexts, or 5, because Sarah is trying to compare 2 different contexts. So it's a good way to think about contextualizing shared decision making. And it would be interesting to hear what is or isn't shared across these 4 contexts. And that might bring up questions about how we should revisit the models and the practices of shared decision making in different clinical contexts, but also from different analytical traditions, how we look at what is going on. So maybe you should very briefly contextualize your context, because it's not something I can easily remember.
Yeah.
And then maybe I'll ask with a question, the one that is more in the forefront of my mind, about Sarah's work, her presentation, and then it might spill over to others.
So I can remember, I can say something about the context that the speakers discussed in their talks. Like Margarida was discussed about patients and students with depression. Sarah, as you mentioned, Srikant, we're comparing two different contexts, hemophilia and assisted reproductive technology. Dulce was addressing the topic of educational therapy in the context of diabetes. And Vito had examples from the context of mental illness and also assisted reproductive technology. So I would suggest, Srikant, that you could pose your question to Sarah now, and then if you have other questions later on during the discussion, just let me know, and I will give to you the word again.
Yes, but I think you must make sure that other participants get the floor. It's
Of
not
course.
me.
Yeah.
So I should be your last resort if you don't get any others asking things.
Okay.
But let me begin with Sarah's, if you want me to.
Yes, please.
The issue here is about assessing the quality of shared decision making. And that question itself, assessing X, assessing something, already makes certain assumptions, certain taken for granted. There is something called shared decision making, which we are questioning and debating, that all kinds of clinical contexts can be put into one category so that a model can be, a tool can be developed to assess, that we as analysts, as opposed to the clinicians and patients, because they can also differ in what is or isn't a decision that is shared or not, on whose side do we find ourselves? So how do we feel competent and comfortable in assessing what may not be shared or agreed upon by the two primary parties whose interaction we are looking at? So these are some of the assumptions we are already making in trying to develop a tool for assessment. And that brings me back to the question we have been discussing this morning. Are we assessing the process itself, that is the communication, or are we assessing the decisional outcome, whether that decision is good and shared and the right one? So if we take an argumentative perspective like deliberation, we might be able to assess the quality of the deliberation, the absence and presence of deliberation in a particular clinical encounter, but that's not the same as assessing shared decision making.
Sarah?
Yes. No, I agree. It's not the same as assessing shared decision making. So I guess my talk started from the idea of, or the possibility of assessing the quality of shared decision making. But then it comes to the conclusion that at least with the tool of the deliberation, of the model of the deliberation dialogue, what we are doing is really assessing a part of the process. So I agree with you that that is not the same thing at all of saying we are assessing shared decision making. I think also referring back to the discussion, the previous discussion this morning, I think what I was trying to get to is that from an analytical point of view, it still is interesting to be able to identify some parts, let's say some elements that are in a process, and in this case, the deliberation process, and that we are able to say that these parts, for lack of a better word, are well formed in a sense or not. And not in general. I agree with you that it's very difficult to talk about these things in general, but referring to a specific context makes it much more reasonable and useful. And this is something I get to after these two studies that I presented in my talk, because when we started out with the one on the hemophilia context, my colleagues and I had not gotten so far in discussing the idea itself of shared decision making or of deliberation. They are a group of psychologists, and they came to me and asked me to collaborate on the relevance of words or structures that led to decisions. And so I was working with this model, and I said, why not try this? But we were not really, criticizing or discussing like we are doing now this idea of shared decision making. Although like I said before, I did feel that there was something a bit slippery about it. So it was only after we then tried to replicate the study in the ART context that the problems came out, as you know, because you were present at that conference where I presented those results, and I appreciated your comments also there. That really showed that you can analyze the process. We did analyze the process because deliberations were present, but clearly they were not the point. So really to discuss the quality of deliberation in ART is always okay. I mean, it's always relevant as an exercise, but it doesn't address the issues that are relevant in that specific context. The issues that are relevant in that specific context are different. So now in the context of this discussion and of this conference, let's say I'm revisiting those studies, and I am revisiting that comparison as a way of saying that I still think it could be useful to have some indicators, some tools, and I mean theoretical concepts and methodological tools, to get a little bit into the structure of the process, at least the deliberation process, or the linguistic strategies that are used, framing strategies or others, as also some of the talks showed. But of course, we cannot just take for granted that shared decision making is a sort of encompassing concept that we can apply just like that to any kind of context.
So thank you, Sara. I can see, thank you, Srikant.
Can I just follow up very quickly?
Yes, of course.
I think what I would like to see is more of if deliberation as a process is not just present in shared decision making or any specific context like hemophilia or ART, then we have to see exactly which aspects of deliberation, the content, if you like, rather than the presence or absence of deliberation can we be more specific about? So I would expect deliberation to be part of unshared paternalistic decision-making as well as shared decision-making. Then we have to come down to say what kind of deliberation is more specific or more sensitive to which kind of thing that we're looking at. And just to go back and connect it to Vito's work, is metaphor part of the deliberation or not? Which kinds of metaphors and how they are developed and taken up in the deliberation process might signal a certain kind of deliberation or participation, like in psychotherapy and other settings, than metaphors in some other contexts. So I think our question is more, it's not so difficult to find presence or absence of something, whether it's metaphors or deliberation or whatever, collective pronouns or whatever in some encounters. Or how do we give it a very specific meaning and interpretive value?
Yeah.
So that what we are saying goes beyond our findings and analysis, because simply to say we found these metaphors, these processes may not be good enough. That's a challenge for all of us. I don't mean just you.
No, I agree.
So, Sarah, I would suggest to you that you could take some notes on this follow-up, because I can see that you have also other questions, but I would find a way also to give the chance to the others. So I move on with a question that is from Olga Blanco, and it's for Margarida. So the question is, why do you think physicians wrongly estimate these patients' needs? Olga here is referring to a specific point discussed by Margarida. Do you remember the point, or I should?
Yes.
So you can contextualize a little bit also for the others.
Yeah, thank you. Yes, because we were performing a study on patients with depression, and we were asking them for how much they want to participate in the decision-making process with their psychiatrists. Just a small introduction. As you all know for sure, depression is really very prevalent in the growing up in numbers, and the most part of the patients are not seen by psychiatrists, are really seen in other medical contexts. But specifically, this study was performed in psychiatrists and in patients with depression attending an outpatient clinic. And I think psychiatrists in a normal setting have just a short time frame for consulting their patients, and they had a big agenda. And I think that shared decision, and even before shared decision, sharing information about the disorder, treatment, and also ways of coping with depression are really left to the bottom of their agenda. So they don't do it by purpose, but in some consultations, for sure, they don't have enough time to ask for patients' doubt, and beginning with their doubt, start to inform. Because we were discussing in the first part of the conference that patients normally don't need the full information, the scientific package of information about the disorder, but they want a tailored information. They mostly want to be that their doubts and mostly their emotions are addressed. And Paul was speaking about shame, but patients with depression also have fears and guilt somehow, and maybe I will organize my thoughts a little bit more so I can be more clear. But I think the first point is to address the information need that patients have. And maybe if you skip that point, you undervalue their needs. I don't know if I answered the question.
Yes, thank you. And also you will have the opportunity to interact with Olga that is here with now today. So Olga, if you want to, if you have a follow-up, please feel free to write again in the chat. In the meantime, I would give the word to Marcin Lewiński. Hi, Marcin.
Hello, good morning. I would just like to start by congratulating you, Maria Grazia, for this. It's amazing, and to all speakers. It's about the 6 online platform I'm learning to use in the last 3 months. It's greatly organized. So I actually, my question has been stolen by Professor Sarangi, so I have to reformulate it slightly. So I also ask on the basis of Sarah's presentation, but I think it's a general question that also applies to all the speakers. So I don't mean to be in any way exclusive, but it's exactly about the evaluating the process and the product. So when I listen to your presentation, and it's also very interesting to me in general because of the argumentation theory background I have and the work on deliberation. So, okay, so you can say, well, the process that you're evaluating, how complete, so in both studies, how complete are the steps of deliberation? But they might be empty steps. For example, you have a question. So I didn't see the details of the study, the methodology exactly, but do patients and doctor consider alternative proposals? And then you tick the box, yes, they do. And then you say, well, it's complete. So you have a box ticked off. But then, you know, how complete is the set of proposals, or how epistemically or medically good are the proposals? You don't evaluate that. So here is exactly I guess the same problem, that in a way the process seems complete, fulfilled, but medically speaking, clinically speaking, is suboptimal, to use this word. So here's my question. Because you asked the question as an open for discussion, that you didn't evaluate the quality, the validity of arguments, but also the quality of the treatment, for example, proposals. I would like to hear something about that. And this is a critical, but it's an open question that is very general also for political deliberation, for any other context. And here is another angle that, okay, so the process, the sharedness, is important in political context, but also in medical context, for some kind of legitimacy of decision, that the people feel more engaged. And for example, in this specific context, I think there are studies that show that patients who are involved in this kind of shared decision, as opposed to the paternalistic doctor or the informed consent models, they better follow the treatment because they feel engaged, and they have a longitudinal, they are better following the treatment, even if so here's my kind of question. When you evaluate also the quality of the product, so the outcome of the deliberation, should you not also include, okay, maybe in a certain clinical sense, it's a suboptimal decision, but then the patients are following better, and it's in the kind of holistic assessment of the product itself, it's better to have it would be perfect for this patient not to drink wine nor Coke, but if the patient just stops one of them, like the doctor suggests, it's already okay. It's not a perfect outcome, but the guy is doing it. So the product itself, okay, you can say it's suboptimal in a certain clinical epistemic assessment, but maybe it's optimal in a certain whole context of therapy, of treatment. And okay, I stop here because it's a long question, but I had to make it so specific because in a sense, the gist of it was stolen by Professor Sarangi. So thank you. And I'd like to hear, perhaps Sarah can start, but also I guess in other contexts, it would be there would be similar dilemmas.
Thank you, Marcin.
Okay, so yes, thank you for your question. Let's see. I would start from here. First, I agree that assessing the completeness of the process is not a complete indicator of the quality, like I said in response to Professor Sarangi. And I also agree that to say that from a dialogical or argumentative point of view, the deliberation is complete is not the same as saying that from a medical perspective, the outcome is good or bad. But that's where the interdisciplinarity of the research comes into play. I cannot say if a decision is good or bad from a medical point of view. And that's where we need to get together and I can provide my evaluation of the process, but then of course this evaluation has to be compared with the clinical side of the matter, and this I think this amounts to or goes in the direction of what Professor Sarangi was hinting at when he was saying it needs to be contextualized, and I think this is how you do it. I think my point is that if you leave out either perspective, you probably tend to understand a little less of what is going on. I am aware, I'm very well aware that decisions in medical interactions are not simply what you see in the dialogue, in the medical encounter. I'm very well aware that there is a lot before, during the encounter, and after the encounter going on. So I surely do not have I do not expect to say that decision, is just a product of this single interaction. On the other hand, I think that if we want to understand a little bit better what, let's say, decision-making is about, we also, on top of everything else, need some ways, some tools, some methods to analyze the dialogical dimension of it. This was an experiment, if you want, and for sure it reveals some advantages, but also many limitations of using this model. Like you say, for example, the validity of the arguments used is not taken into consideration. But then again, as you were saying, perhaps the argumentation stage might not be complete, but in the end, the outcome is good from a medical perspective. So what we were referring to, especially in the first study, where we did a little more work on justifying the adoption of this method, was to resort to the literature on behavior change. So, the fact that, for example, a person has the opportunity to advance a proposal, which is very similar to what Walton says when he is designing that model, or the fact that a person actually commits to a proposed course of action, which means that the closing stage is full, it's not empty. And according to that literature, these are all things that really foster behavior change because they foster motivation, engagement. And so since the initial question was coming from the clinical world and was referring to this problem of adherence to treatment or to healthy lifestyles, especially in areas such as diabetes or these kind of conditions, it seemed like a good starting point, at least, to see if all the parts of the deliberation process were there. It's a starting point. Of course, the ART context is so different that, also in the premises, probably there was, the results were probably already announced in a certain way because they have completely different goals and needs.
So thanks, Sarah. Thanks again, Marcin. And we have this question that is for you all. Are you aware of a study regarding a comparison of the gender part of discourse connected to lifestyle changes across different medical branches? That is always a question posed by Olga Blanco, and also I would encourage you to ask questions each other if you have questions or comments. I will give the word now to Giulia Manichetti. Hi Giulia, welcome.
Yeah, can you hear me?
Yes.
Yeah. Thank you, Maria Grazia. I would like to start also by thanking you for organizing this. I think it's, very successful realization, and thank you for the all interesting speeches. I was so one curiosity that I actually this morning of this discussion opened a lot of thoughts in my mind, but there is one which I probably would like to put on the table for all of you. As you have said at the beginning, you represent different contexts and you have studied different clinical contexts. Actually, this talk starts from my experience in the ART field, as Sarah has also analyzed videos there. And I was wondering, so we see patient autonomy, patient engagement as a sort of delight, sort of a direction, a goal to look for, and that can guide our actions. We see cases like, for example, it's the ART case, where usually patients are very much informed, engaged. I mean, they already have a clear point of view, decision in their mind. And I can see that also in other settings, we are probably seeing more and more of situations where doctors and in general, healthcare practitioners, confront with patients who are very prepared and that challenge sometimes also the point of view of the doctor. So yeah, I was, and I'm convinced that also maybe I was thinking also of the work of Margarida with technologies. I also think that technologies are playing a big part in making individuals, making us informed from different sources. So sometimes we arrive already at a consultation with our strong and clear ideas about what we want and what we expect to receive in terms of care and treatment. So I was just wondering, so as we usually see at patient autonomy and patient engagement as the final direction, but I think there are many situations where we are seeing that having an active informed patient on the other side can pose challenges to the doctor, and how doctors, and so how this is this can also, I mean, shape or made us and doctors reflecting also about the decision-making process there. So I don't know. I hope it was clear. I will be very happy to hear your reflections and experiences also in the different context about these.
So who starts? Margarida, yes? Go on.
Yeah, okay. Yes, thank you very much for all the questions and comments. And well, it's really a pleasure to share all our ideas with everybody. I think time is running, Maria.
Yeah.
So I will keep brief. Yes, we were also very curious about understanding how these all digital tools that now all patients and everybody in general have access to can influence patients' preferences and needs for information, for instance. For sure, we have several steps. The ultimate goal is to share eventually which is the best decision for that moment for that patient in that context, and that it's beyond clinical guidelines or even clinical outcomes, because as you all said and stated before, it's very important that more than patients are comfortable and empowered in their decisions, so they can be emotionally also very well, and it's very important all this process. But taking your question specifically, besides getting all this information that is at disposition of our patients, we understood that patients prefer clinicians' information, so they need clinicians to balance, and they are eager for the clinicians to lead them through this forest of sites and chats, and so they need clinicians to tell them where is the quality of the information, so they can be there and decide, starting with the best point ever. Okay, so they balance both, all the digital information, but they need a direction from the clinicians, and they privilege clinicians' guidance. Okay.
So I just want to let you know that we have a parallel discussion on the chat with the comments given also by Paul Gulbrandsen and follow-up given by Olga Branco and Irene Carvalho. I would suggest just to, if you have questions for the others, to do it now, just to have the opportunity to listen also to the others. Sarah, yes?
Yes, I actually had a question for Vito, and the question is, speaking about assessment in its with all its limitations, let's say, but would you say that, for example, the use of metonymy could be used as an indicator, one indicator of communication quality in medical interactions? And since I just have the floor, can I just add a question also for Dulce? So then I stop talking. I wanted to ask, where do you see the biggest challenges for clinicians to be able to conduct effective therapeutic education? So from the point of view of the clinician, what is your experience or perception that the biggest challenges are in the conduction really of effective therapeutic education?
So maybe I'll start. So we know that the way that people use language, what people are saying, it does give insight into how they're behaving and how they view their own personal worldview. So in the case of assessing, that's something that I sort of showed in one of the examples, where once we start seeing that there's a decrease of use of this type of pathogenic metaphor, that sort of indicates also a type of healing of the person, right? So I don't think we might want to talk about like a correlation, but it might be an indicator, right? So when people start changing the way that they use metaphors or metonymies, when people start changing the way that they talk about things, first of all, it means that we talk about things that are most important to us, right? So if we're not talking about that thing anymore and using those terms, it probably means that it's sort of receded. So yeah, I do think that being able to track the use of language, whether it's metonymy, whether it's pronouns, whether it's metaphor, it is an indicator. Yeah.
Thank you.
Thanks, Vito. Dulce, I don't know if you have something to...
Yes. If I understood, the question is what is the challenge for therapeutic education? One of the big challenge is the time, because therapeutic education requires time, but we need to think that this approach is a continuous process developed in each consultation, and in my opinion, the way that we relate with the patient and we communicate makes the difference. If in the few minutes that we have in each consultation, we can establish a motivational and interactive relationship, and that can help the patient. Another huge, I think, a challenge is the way that we communicate and to guarantee that the patient understood us. The patient needs to understand the message to be able to participate in the therapeutic process with informed decision. In all Europe and perhaps in the world, we have a low health literacy, and the patient don't understand us. And if they don't understand the message, they never can have informed decision. So I think that it's a huge challenge to guarantee that the patient really understood the health information that we gave him to decide. I think these two, because in some way the healthcare professionals are developed the capacities of the communication. I believe so, but now I think it's very important to create knowledge, to know how to communicate with them, because now we know that patients need to understand really what we are saying. So for me, I think these two are the biggest challenge.
Thank you.
So, thank you, Dulce. We have now a question from Dima Mohammed. Welcome to Caring Discourse, Dima.
Thank you, Maria Grazia, for organizing this conference, and thank you all for really interesting and stimulating talks. So my question is a bit general to everyone, but there's something particular for you, Saida. So as I was listening to the keynote speeches, but also to your talks, the question of asymmetry of knowledge and expertise kept coming to me. So, of course, I understand that moving away from the traditional models, we want to empower the patients, and that's why we think of shared decision-making, of informed decision. But of course, with all the challenges that these models have, I think a great challenge is to know how to deal with the asymmetry of knowledge and expertise. So after all, doctors know much more. We patients, even when we know and we want to share the decision, we cannot be taken as equals. So my general question is like, how do you see that influencing the ideal model, like let's say the next step? So what's after shared decision-making or informed decision-making, the model that takes the asymmetry of knowledge in a way that reassures the patient, because if the patient feels too much burden, it's also not empowering. So it's reassuring the patient and empowering them, so not taking their agency away. So that's the general question. For you, Sarah, I would say, especially if you think of deliberation, this is really crucial, because deliberation works on the premise that we are all equal citizens, and that there is not such a strong asymmetry of power. So if you want to apply the model of deliberation, I'm sure you thought about that. So I was curious, how do we take into account the asymmetry of knowledge in general for the consultation, but particularly if you want to use the deliberation model as an assessment for the quality of the process, not the outcome, but the process. Thank you.
Maybe if somebody else wants to address the first general part of the question first. I've talked a lot so far.
Yeah, Margarida.
Okay, well, I'll say something. Yeah, so shared decision making isn't my expertise at all. And as a cognitive scientist, for me, I was sort of thrown back by this thought that there is shared decision making, right, between a doctor and a patient. When I go to a doctor, I don't want to be the one deciding, you know, I want them to decide. I want them to tell me what's best. I can see how there are cases where the patient wants to be engaged. I'm thinking of like situations with my grandparents who would go to the doctor. They might not have anything. The doctor might sit and listen and give them a placebo, right? So there's a lot going on there on an epistemic level. First, what's happening with the patient, and then what's going on with the doctor and that communication between them. I totally agree. There is this huge asymmetry, but even an ethical asymmetry. You know, I was trying to talk about that in my presentation, where ultimately the doctor is responsible of whatever outcome. So I can understand engagement. I don't know if I understand the shared part. So yeah, I'm interested also in that. You know, is what are you judging it on? Are you judging it on the patient satisfaction, the fact that my grandparents might go and they said that they had a problem and that the doctor gave them a placebo and all of a sudden they're happy? Or are you evaluating something else? Yeah, just a little comment. Yeah.
Okay, can I add something?
Yeah, please.
Yeah. Thank you for this wonderful question, because it's really, in my point of view, and not only mine, this asymmetry, it's not so real. I think that we are trying to build a new conscience in doctors, that they need information from the patient that is particularly useful. So we are trying to build a shared communication through all consultations, starting with the beginning, so that doctors get used to give patients a voice and listening and eliciting patients' point of view, expectations, and also specific information that doctors don't possess at all. So this asymmetry, it's not so real as we think at the first sight. So we really need to get patients involved from the beginning, so that doctors also understand that they don't have all the knowledge. They have to share their knowledge, but they also have to gather from the patients very, very important and specific information. So they also, as clinicians, can find the right proposal and the best fitting proposal for that patient, and then be able to negotiate it with the patient as a pair, not in an equal perspective, but as both a collaborative approach and relationship.
Sarah, I'm curious to listen to your answer now.
Yeah, so no, thank you, Dima, for the question. Yes, I have, of course, been thinking about asymmetry because it is a major challenge in this kind of interaction. And my tentative response to that is that actually I see in the opportunity of discussing, so in the opportunity to use argumentation within an interaction, perhaps in the deliberation phases or not, is a way of addressing the challenge of asymmetry, because I agree that you cannot do away with asymmetry. It would mean destroying that kind of interaction at its roots, because the asymmetry is the reason why we go to see a doctor. Otherwise, we would solve the problem by ourselves, I suppose. So if there is an asymmetry, if we go and see this expert, it's because we want to somehow use his or her expertise. So that cannot be eliminated, but of course it can cause big challenges. And one thing, for example, that I've noticed is that because of this asymmetry, and this is something I think both the keynote speakers mentioned, it's not that every time we have illimited options. Right? Sometimes we don't have options. Sometimes we have one, sometimes we have two, and that we know from the doctor. So the doctor sets the agenda, if we want to call it this way, of the discussion. Upon entering the argumentation stage, if we want to refer to that model that I used, the doctor sets the agenda saying, these are the options. So now perhaps we can start discussing how we want to proceed with this. And I think that the opportunity for the patient to put forward proposals is really the opportunity to work on that asymmetry, to create that sort of common ground that allows the clinician to then understand where the patient comes from, at least those aspects that are relevant to the issue. So perhaps the skill, one of the primary skills that should be taught, is to ask the right questions, I suppose, because it's not everything is relevant to the discussion. And sometimes patients may feel that something is relevant when maybe it is not from the point of view of the doctor, but then of course, I already hear the objection, but who decides what is relevant? Because if it's relevant for the patient from the point of view of his or her well-being, then it is relevant, and I agree. But then if a medical decision has to be made, there are certain aspects that need to come into the discussion necessarily. Okay, so I think this is the thing that I would like to say with regard to asymmetry.
Thank you, Sarah, and thank you also to you, Dima. Paul, I know that Paul has a question, so hi, Paul, again. Is that true? Do you have a question? Yeah.
Yeah. Well, you asked me whether I had a question to these speakers, and Margarida is a psychiatrist, but I am just a general doctor, and meeting your interdisciplinary expertise. And I would just be I feel it's sort of towards the end of the discussion.
Yeah.
I have this question for all of you that have made this discussion. What would be your single most important message to me as a teacher of medical students and young doctors?
Thank you, Paul, for your question. It's not so easy to answer, I think. Just let me check, because I can see that Margarida has some problem, but she's not here. So who starts here?
I've talked too much. Let the others go first.
Okay, well then, my suggestion would be don't listen just to the words.
Sorry, Vito. Just to help Margarida to understand what is going on. So, no, not a problem, Margarida. So, Paul asked, Paul, you can.
Yeah, I had this question for all of you. What would be your single most important message to me as a teacher of medical students and young doctors?
So please, Vito, continues.
Yeah. So for me, it would be to learn how to read between the lines. So rather than just listening to the words that are being used, also think of how the choice of words might help frame and provide a better context of, what these people are thinking about and what their own background sort of is. So, are they talking, are they using one synonym versus another? What does that choice of word tell you about how they think and what they want and where they're hoping to get with you? Yeah.
Thanks, Vito.
Thanks.
Sarah?
I'll go then. I think I would help them become aware of what idea they have of the process of communication. Because, and I say this because I've participated in a few times now in training events for clinicians. And I took the habit of beginning by asking them what they think about the communication process. And most of the time, they come to me, they answer me with the mathematical model of communication. And I think that is a problem because if you learn the techniques and then sort of have that in mind, nothing will work because you're considering communication just as a transmission of information, and then you're really frustrated if nothing happens on the other side and a behavior doesn't change and an information is not understood. So I guess one of the things I would consider important is to help them become aware of what idea of what model, if you want, of communication they have, even intuitively, or that they studied. Then, of course, it's not easy to pick the model that is more appropriate, but at least becoming aware of what you think about the process, I suppose, could be useful.
Super. Thanks to both of you.
I don't know if Margarida and Dulce, do you want to add something on this? Yeah, go on.
Okay. I suppose one important thing, in my opinion, is to students to see the person beyond the disease. Don't see only the patient, but the person. If they saw the person, they can understand their needs, their knowledge, what they want, their goals, and personalize the information, the answers, and adapt to the patient. Of course, communication, it's very important. Read the non-verbal communication, I think it's very important. And in the one consultation, I think that in the ending, evaluating what the patient understood. Sometimes the healthcare professionals make highlights what they said, but it's important to give the opportunity to the patient to talk and say what they really understood. And it's a magic moment because sometimes in the end of the consultation, we saw that our consultation don't follow what we thought. The patient don't understood everything that we are talking. So it's very important evaluation in the ending.
Thank you.
Okay. So many important things are already said. So I would try to foster the ability to be good listeners, both at the verbal and non-verbal level. Because I think young doctors are already taught how to, well, normally what to say. Maybe not ever, not always, has how to say it. So I would emphasize the ability to listen and also the ability to put the right words for the right patient. So to tailor information regarding literacy, regarding personal levels and the personal characteristics, as it was already said, so they could really create a collaborative relationship. And I think it's a lot of advice, not just one. But I think if I have to underscore one, maybe the ability to shut up and listen and observe.
Thank you very much.
Thank you.
It's interesting that you use the word tailor, because my textbook on medical communication for doctors in Norway is called Tailor Talks. So, one message back to you that we haven't discussed, but that I would like you as researchers to be aware of, and that is particularly for young doctors, that they have an enormous cognitive overload that actually hampers their normal communication with people. And keep that in mind, because it's actually when they're in that position, young and trying to become good doctors, they have so much here, they actually start doing things in a way that's not very functional, very efficient, and unfortunately they're not corrected and they stay there.
Sorry, I'd like to add something and to answer in some way also to your question, Paul. And to answer, I'd like, I'm not staying at the communicative level, but I just want to continue what you were saying just 1 second ago, and what you also discussed in your talk. So I'm talking about the importance of vulnerability that you stressed a lot in your talk, but also of the value of humility. And I think that you are always are able to show these two properties from what I know. So I know that your students are learning from you at least these two values that for me are very important. So thank you.
Thank you.
I think, yes, that we are also at the end of this question. I can see Srikant, so just give me a sign if you want to add something. If not, we are, no, it's a no, okay. Ciao, it's just a bye, see you later, okay? Yes, thank you. So, thank you so much. I really appreciate this discussion. We come back at 12 with the poster session and the award ceremony for the Best Poster Award. So remain to support our students and junior researchers. Thank you.
Thank you.